Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 442 of our pharmacotherapy series, which majors in prostate cancer. The next case reads: Patient SHL is a 63-year-old male with a clinical stage T1CN0M0, prostate-specific antigen 9.2, Gleason 4+3, which is equal to 7 prostate cancer. His past medical history is unremarkable and he has an excellent performance status. He has no known allergies and is not on any medications. His labs are not clinically significant other than his prostate-specific antigen level. When presented with his options, SHL decided to undergo a radical prostatectomy for definitive local treatment, which revealed a pathologic stage T2CN0M0. He was monitored after surgery and after 6 months had no symptoms from the procedure or the disease. His prostate-specific antigen was monitored and his nadir after surgery was 0.32 nanograms per milliliter. The medical oncologist believes that the cancer is still present, but does not think there is any indication of disseminated disease. So my question to you reads: what type of cancer progression does SHL have? We will briefly look at recurrence and progression. For patients who have definitive local treatment with either radiation or surgery, about 25% to 33% of patients will experience a recurrence of their cancer. After the completion of local therapy, patients are monitored by periodically checking prostate-specific antigen for the detection of biochemical recurrence, which is recurrence of disease as indicated by rising prostate-specific antigen with no other signs or symptoms. The threshold for prostate-specific antigen recurrence is dependent upon the initial treatment given. Because a radical prostatectomy involves the removal of all prostate tissue, serum prostate-specific antigen after the procedure should become undetectable. A prostate-specific antigen level of equal to or greater than 0.2 nanogram per milliliter following a radical prostatectomy is considered a biochemical recurrence. Risk factors for the development of a recurrence after radical prostatectomy are the Gleason score, positive surgical margins, and elevated postoperative prostate-specific antigen levels. A biochemical recurrence after EBRT is defined as a rise in prostate-specific antigen level by equal to or greater than 2 nanograms per milliliter above the nadir, or lowest achieved prostate-specific antigen, or 3 consecutive prostate-specific antigen rises above the nadir according to the American Society of Radiation Oncology, abbreviated as ASTRO, criteria. Risk factors for recurrence after EBRT include large volume of disease, short time to prostate-specific antigen recurrence, invasion of extra-prostatic organs, and high Gleason score. As SHL is not symptomatic and his only evidence of disease is his prostate-specific antigen rise that never became undetectable post-prostatectomy. He has biochemically recurrent prostate cancer. My next question to you reads: what is the most appropriate treatment for which SHL may be eligible? A biochemical recurrence can indicate that a patient has either a local or metastatic recurrence. A patient thought to have local recurrence may be eligible to again receive local therapy, called local salvage therapy, providing a chance for a cure or a delay in progression. A patient with a biochemical recurrence after a radical prostatectomy with no indication of distant metastases may be a candidate for salvage radiation therapy with or without ADT. Conversely, a patient initially treated with radiation therapy may be a candidate for salvage prostatectomy. In addition to salvage prostatectomy, cryotherapy, which is a procedure that freezes cancer cells, and brachytherapy, if EBRT was first used, are also salvage therapy options post-radiation therapy. Careful consideration of the characteristics of both the disease and the patient must be assessed in order to determine the appropriateness for salvage therapy. In patients with clinical features suggesting that the disease is no longer confined to the prostate, called disseminated prostate cancer, systemic therapy is indicated. As prostate cancer is hormonally driven, ADT is the initial standard treatment in recurrent prostate cancer. At this point in the disease, patients are considered castrate-sensitive as their cancer is still being suppressed by the lowering of testosterone to castrate levels with ADT. Androgen deprivation therapy is palliative, but it can control or delay symptoms and complications, improving patient quality of life. Because the benefit of ADT for biochemical recurrence is still not fully known, when to initiate ADT is still not clear. Observation until evidence of progression is an option. However, patients with rapidly progressing disease, as indicated by the presence of symptoms, an elevated prostate-specific antigen, or a rapid prostate-specific antigen velocity with a long life expectancy, should initiate ADT earlier. With long-term use of ADT, cost and the extensive side effect profile may be limiting and will impact the quality of life for some patients. Intermittent ADT, once there is response to treatment, rather than continuous administration, is an approach that can minimize side effects and improve quality of life. With this approach, patients continue ADT until maximal prostate-specific antigen response and then temporarily stop ADT until a set prostate-specific antigen threshold is reached, at which point ADT is reinitiated. The full benefit of intermittent ADT is still not known. A trial done by Crook and colleagues assigned 1,386 men with rising PSA after radiation therapy to either intermittent ADT or continuous ADT. The intermittent ADT approach was non-inferior in terms of overall survival, 8.8 versus 9.1 years. Hazard ratio of 1.02, with a 95% confidence interval of 0.86 to 1.21. But more patients in this group died from prostate cancer, 120 out of 690 versus 94 out of 696. The trial demonstrated an improvement in quality of life with intermittent ADT. However, more research must be done to determine the true impact on survival. This approach may be considered for well-informed patients without metastatic disease. The duration of response from ADT varies, but eventually the cancer becomes resistant to ADT and most patients progress. At this point in the disease, SHL has recurrent prostate cancer without evidence of disseminated disease. Because it is thought that the disease is a local recurrence, he may still have an opportunity for a cure with local salvage therapy. He was initially treated with a prostatectomy, and salvage therapy should consist of EBRT with or without ADT. SHL undergoes local salvage therapy with EBRT and ADT with Luprolade. After EBRT is completed, he is monitored while continuing ADT therapy. His pertinent laboratory results are as shown in the table. Pause the video and carefully scrutinize it before advancing to the next slide. SHL continues to be in good health, other than experiencing mild depression and 3 to 4 hot flashes a day. Bone density scan results on 19 April 2015 shows osteopenia with a T-score of -1.5. Bicalutamide was added to his ADT treatment plan on 19 April 2015. So my next question to you reads: how has SHL's cancer progressed? What should SHL's medical oncologist do next? Castration-resistant prostate cancer, abbreviated as CRPC, occurs when the cancer no longer responds to ADT alone, and the cancer is progressing despite castrate levels of testosterone. This is indicated by a rising prostate-specific antigen or by new or progression of existing metastases. At that time, there are a number of different therapies that can be used, including chemotherapy and immunotherapy. Castration-resistant prostate cancer has acquired mechanisms of resistance that upregulate androgens and/or androgen receptors, enabling the cancer to grow in the presence of ADT. This continued dependence on the androgen pathway allows for castration-resistant prostate cancer to be sensitive to additional agents that affect androgens and the inhibition of androgen receptors, despite its name suggesting tumor resistance to further androgen manipulation. A gonadotropin hormone-releasing hormone abbreviated as GnRH agonist or antagonist should be continued indefinitely while undergoing any other therapies to continue its inhibitory effect on testosterone and dihydrotestosterone. If a patient has a rising prostate-specific antigen level while on ADT, a testosterone level should be rechecked to make sure it is below castration levels. If it is not, then ADT is not adequately blocking the production of androgens, and a change in medication or an orchiectomy is usually recommended. If the testosterone level is below 50 nanogram per milliliter, the patient is confirmed to be castrate resistant and additional systemic treatment will be necessary. We will now briefly look at secondary hormonal therapies. Despite the fact that the cancer is now labeled castration-resistant, many cells are still very dependent on the androgen receptor and can continue to be targeted throughout the disease. For a patient who has adequate castration levels, that is less than 50 nanograms per deciliter, while on a gonadotropin hormone-releasing hormone analog and has a significant rise in prostate-specific antigen level or clinical recurrence, they will typically be responsive to secondary hormonal manipulations, such as antiandrogens, antiandrogen withdrawal, ketoconazole, glucocorticoids, and estrogens. These agents can delay disease progression and postpone the need for therapies with increased toxicities. However, they have not shown a survival benefit. It is possible to use these agents sequentially prior to initiating a different approach. The addition of an antiandrogen for combined androgen blockade is a common initial treatment for castration-resistant prostate cancer patients. As mentioned earlier, there are 3 approved antiandrogens that are used in this setting: bicalutamide, nilutamide, and flutamide. Because of the multiple daily dosing of flutamide and the additional side effect of delayed dark vision adaptation of nilutamide, bicalutamide is typically the preferred agent. Although these agents are generally well tolerated, adverse effects can include hepatic toxicities with elevations in liver enzymes. Monitoring of liver function tests are recommended with the use of these agents. Gastrointestinal toxicities can occur with these agents, particularly flutamide. Nilutamide has the highest rate of pulmonary-associated side effects, although it is rare with any of the antiandrogens. Discontinuation of an antiandrogen after progression on combined androgen blockade can result in a decline in prostate-specific antigen level, called antiandrogen withdrawal syndrome. This response can be seen in approximately 20% of patients and should be attempted prior to initiation of another treatment. Ketoconazole is an antifungal agent that is an inhibitor of adrenal androgen synthesis. The testes produce nearly 90% of testosterone in males, with the remaining 10% derived from the androgens produced in the adrenal glands. The androgens are subsequently converted to testosterone and dihydrotestosterone. In the setting of prostate cancer, ketoconazole is administered orally as 400 mg 3 times daily under low gastric pH conditions to allow for maximal absorption along with a low-dose glucocorticoid. The prostate-specific antigen can be reduced by 50% or more in up to 71% of patients. This drug has an increased potential for drug interactions as it is a potent inhibitor of CYP3A4. Toxicities include nausea, vomiting, rash, and fatigue and are often limiting for patients. Several different glucocorticoids and estrogens have historically been utilized in the treatment of prostate cancer. It is still unknown exactly how these agents act in castration-resistant prostate cancer. It is thought that estrogen can cause suppression of luteinizing hormone release from the pituitary to then reduce testosterone production in the testes. They may also have a direct cytotoxic effect on cancer cells. Conjugated estrogens and estromestane have also shown response rates of 24% to 42%. Glucocorticoids, such as hydrocortisone, dexamethasone, and prednisone may suppress adrenal androgen synthesis by reducing the production of adrenocorticotropic hormone, ACTH, in the pituitary. These agents have somewhat fallen out of favor given the toxicities and the increased number of options that are now available. SHL now has castrate-resistant prostate cancer confirmed by the rise in prostate-specific antigen despite testosterone below castrate level. The medical oncologist had added an antiandrogen to SHL's treatment plan, which he initially responded to as indicated by his prostate-specific antigen, but at his next evaluation his prostate-specific antigen rose because of an acquired mechanism of resistance. The next step for SHL would be to discontinue his antiandrogen for a withdrawal response. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 443.